Assalamualaikum and a very good morning. I am Dr. Khairul from Hospital Kuala Lumpur. First of all, I would like to thank the organizing committee for inviting me as a speaker for this congress. My topic is Sleep Safe, the RA Dilemma. This is the outline of my presentation. First, I will give some introductions. Then I will dig a little bit about the controversy, mainly the peripheral nerve injury and local anesthetic systemic toxicity. Then the conclusion. It is generally been accepted for many years that intraneural injection during attempted nerve blocks may lead to nerve injury. However, there is no clear-cut definition of intraneural injection. Is it deep to the circumneurum or paraneurum? Or most of the anesthesiologists accept that it is inside the epineurum but outside the perineurum. To shine you some lights, here is the microstructures of the sciatic nerve. 4 structures you need to identify. The first one is the outer blue-colored layer, the epimysium. This is when your block needle pierces this layer, you will feel a pop or loss of resistance. The next layer is this red-colored layer, the circumneurum. Then the deep blue layer, which is the epineurum, and the brown-colored layer, which is the perineurum. Some researchers agree that the intraneural injection defined as the injection deep below the circumneurum, and most of the anesthesiologists accept that intraneural injection is between this epineurum and perineurum. Blocks in anesthetized patients are contraindicated because inability to report warning signs of potential nerve injury or signs of lust. However, this statement received a massive counter-argument, especially from the pediatric anesthetists. They published a joint statement saying that it is considered safe and best practice to perform regional anesthesia in anesthetized children. For the first 70 years of the 20th century, RA was performed in conscious, awake patients. Motor stimulation responses could be elicited in patients whether they were awake or asleep. Because of this statement, performing RA in a sleep state became more accepted and widespread. This is true in English-speaking world, which prefers a sleep RA. Whereas in European countries, they prefer awake RA to avoid the risks associated with GA. Now, let's discuss 2 case reports related to this controversy. In 1998, Bromage and Benamov reported the case of a 62-year-old patient who became paraplegic following the incisions of an epidural under GA. They concluded that complication could have been prevented in patient if patient been able to report paraesthesia. In 2000, Benamov reported 4 patients who had sustained spinal cord injuries as a result of interscalene blocks performed whilst they were asleep. They concluded that GA was a relative contraindication to the performance of interscalene brachial plexus block. Because of this controversy, ASRA published a practice advisory for RA in anesthetized or heavily sedated patients and made specific recommendations. In the discussion, they state that GA or heavy sedation removes all opportunity for the patient and or physician to recognize, report, and respond to an atypical symptoms during block placement. Therefore, the weight of the panel opinion is that RA should not be performed in adults with concurrent GA or heavy sedation, except in those circumstances when the physician and patient conclude that benefit clearly outweighs risk. Nerve damage following RA may be related to direct needle trauma to the nerve, neurotoxicity, and compression. It is also important to recognize surgical factors may also be causative. Post-surgical peripheral neuropathy following shoulder surgery has also been reported with rates of RA lower than without block. So now, let's see the incidence of nerve injury. Borget collected a data in 700 patients receiving interscalene block. 8% reported paraesthesia, dysthesia, or pain 10 days post-surgery, which decreased to 2.4% at 1 month, 0.3% at 3 months, and 0.1% at 6 months. 2 patients had sensory motor deficit, which recovered after 19 and 28 weeks respectively. No neurological sequelae following 1001 continuous popliteal nerve blocks with catheter. Alroy et al. Reported 56 major complications in 158,083 peripheral nerve blocks, which is 0.035%, following which 26 were short-lived neurological sequelae. The rates varied between blocks. For popliteal sciatic, the rate is 0.315%, femoral 0.03%, interscalene 0.029%, axillary 0.018%. However, no data is given on the use of sedative or GA. Comparable data from Barrington and Sides rates of nerve injury is 0.04% and 0.09% respectively. HKL experience. For the past 5 years, the incidence of peripheral nerve injury is 0.55%, which is higher than previous data. However, I need to highlight here that most of the complaint is numbness more than 24 hours, and most of them recovered less than 72 hours. In 2020, the rates for peripheral nerve injury in HKL is 0.04%, which is comparable with Barrington's data. Permanent nerve injury, which is more than 6 months, is rare. In fact, in HKL, there is none. It is important to note that the use of ultrasound does not prevent intraneural injection. The ultrasound image did not allow us to identify which part of the injected solution had intraneural spread. In 2006, Bajelson published his work where he deliberately injected LA intraneurally. This resulted in excellent nerve blocks without evidence of nerve injury. Multiple authors have subsequently reported that peripheral nerve intraneural injection is not only a frequent occurrence and has been for many years, but is also probably safe and even desirable. This notion has been challenged recently. Nerve penetration is not always associated with injury. Bajelson reported that it occurred commonly and was not usually associated with neurological sequelae. Intraneural injection has, however, been associated with prolonged block and neurological deficit. The general consensus is that we should try to avoid subperineural injection of LA. Death following peripheral nerve blocks. Yanovsky et al. Described a death following interscalene block and catheter placement under GA. The block was performed using the Winnie approach, which is landmark technique, with nerve stimulator. A 18-gauge Tohi needle was advanced until biceps contraction was obtained. 40 mL of 0.25% bupivacaine was slowly injected. No resistance to injection or aspiration to fluid. A 20-gauge catheter was then threaded 7 cm beyond the needle tip without resistance. Post-operatively, he was extubated, regained consciousness, and pain-free with full motor paralysis of the right upper extremity. In ward, he reported pain score 3 at rest and 4 during movement. So we top up 10 ml of bupivacaine 0.25% in 3 fractionated boluses every 2 to 3 minutes. No change in patient's status and hemodynamically stable, so we left the patient. However, the next morning, he was found dead in his bed. Post-mortem radiography after dye injection into the catheter confirmed intrathecal placement. So, what can we learn from this case? First, the landmark technique has been shown to direct the needle towards the neuroaxis. The catheter was inserted 7 cm beyond the needle, which is too deep. The original dose was not delivered via the catheter, so the top-up was the first check of catheter. The catheter was not imaged in any way. Unlike using ultrasound, we can see the spread of LA through the catheter. The volumes were higher than currently used. They used 40 ml bolus of 0.25 bupivacaine and 10 ml for the top-up, which is high volume and dose for the interscalene block. Patients should be observed for 20 minutes after top-ups. What about last? LA toxicity will be recognized earlier in the awake patient, enabling cessations of injection and reduced risk of cardiac arrest. No data, although GA or sedative medication may increase the seizure threshold and thus be protective. The incidence of last RPEF study and Mayo Clinic reported between 0.1 to 1 per thousand in 2008. Barrington and Kluger reported an overall rate of 1 per thousand in 25,336 in Aurora database. In 12,668 ultrasound-guided blocks, sites recorded no seizure or cardiac arrest. Group analysis reported ultrasound accounted for 12 cases in 20,401 peripheral nerve blocks, which is 0.058%. Only one case suffered a cardiac arrest during a paravertebral block performed without ultrasound. Interesting features that increasing use of ultrasound and decreased LA dosage with time. HKL experience. For the past 5 years, the incidence of LAS in HKL is 0.027%, which is about 3 in 10,000. These numbers is less than RPEF study and Aurora database rates, which is 1 in 1,000. In 2019, in HKL, we have 2 reported cases in 2019. So this patient fitted for 3 minutes after 10 ml of 0.375% ropivacaine is injected for PEX blocks. Seizure aborted after given IV Valium and intralipid. For the second patient, only complained of prodromal symptoms. He only complained of feeling difference, which we interpret as aura. So we immediately stopped the LA injection. Ironically, this incidents occurred just after a few weeks of the first incidence, and we were a little bit cautious at that time. So does GA and heavy sedation affect the ability to detect last signs? Only 60% of cases features the classical signs, and the risk period extends to 30 minutes after injection. There are 3 forms of LA toxicity. The first one is fast last, which results as a direct IV injection of large volumes of LA, results in rapid CV collapse and seizures. The next fast last due to accidental intra-arterial injections, which results from short-lived seizures and is rarely fatal. Slow last from slow absorption of LA, dependent on the plasma-free LA concentration. The effect of slow absorption may occur up to 30 minutes after injection and is seen with large volumes of LA. Sedation may be protective as sensitivity is decreased to 20 to 40%. The effects may not be seen until injection is completed or may occur so rapidly the patient cannot recognize the effects. The propensity for an individual to develop LAS is not just based on dose, but also on the PK/PD of each individual. More than 50% of cases occur long after administration of LA. GA or heavy sedation would not have influenced this. Ultrasound has been shown to reduce the incidence of LAS, and the practice advisory from ASRA is still valid. The potential ability of GA or heavy sedation to obscure early signs of LAS is not a valid reason to forego performing peripheral nerve blocks in anesthetized or heavily sedated patients. So, as a conclusion, there are a few questions need to be considered before we decide to perform RA in an awake or asleep state. The first one is paraesthesia is an early warning sign before permanent neurological injury. It is actually unreliable. Do paraesthesia inform the anesthetist that he has entered the subarachnoid space and is entering spinal cord? This is also unreliable. Paraplegia can be avoided if the patient is awake. Until now, there is no data to prove this. Peripheral nerve injury may be prevented if the patient is awake. This is also no data to prove. Lastly, LAS will be recognized earlier in the awake patient, enabling cessations of injections and reduced risk of cardiac arrest. Unfortunately, this also has no data. So, this is my references. Thank you.